Today's topic is on Uroradiology Part 2. And in this Part 2 of the Uroradiology lecture, we are going to start with hematuria and renal masses. Now, hematuria is the introduction of blood in the urine. Now, it can be both microscopic, that it is not visible with the naked eye, or it can be macroscopic or gross hematuria, which is also referred as frank hematuria, which stains the urine red. And this is the kind of hematuria that requires imaging, that requires further evaluation and diagnosis, because microscopic hematurias are usually self-limiting and sometimes minor symptoms of other diseases. Now, where does that blood come from for the hematuria? Usually, the site resides either in the vasculature of the kidneys, it can be the either or the both kidneys, it can be ureter, it can be the urinary bladder, or it can even be the urethra. Wherever vasculature is high in the urinary system, any damage will lead to hematuria. And a hematuria in a urinary system, especially the macroscopic one, is of special interest because it must be evaluated further, it must be examined, and it must be treated. So, as for the anatomy of the urinary system, it's a simple one. Bilaterally, we have kidneys in the flank region of the abdomen, which is connected with the urinary bladder via the ureter, and it has two junctions: the ureteropelvic junction with the kidney and the ureterocystic junction with the urinary bladder. And then from the urinary bladder, the urine is voided through the urethra. Now, the anatomy of urethra is different in both the male and the female. Now, what kind of modalities we use in hematuria and the renal masses? The first one that we use is the cystoscopy. Now, cystoscopy is an endoscopic process through which either a solid cystoscope or a flexible one is introduced inside the urethra, and the inside of the urinary bladder is examined. Now, cystoscopy can even be further introduced inside the ureter and even the kidneys by ureterorhinoscopy, which is an attachment for the cystoscope. Now, cystoscopy is usually indicated when the source of the blood is gross or frank. Microscopic hematuria does not warrant any mechanical intervention because instrumentation is one of the leading causes of urinary tract infection. So if cystoscopy can be avoided, it should be. Next is the ultrasonography. Now, the cause of the hematuria and the renal masses can be quickly and easily diagnosed or provisionally diagnosed through ultrasound, which give us a very fast and reliable initial differential diagnosis. Though it has its limitations, and if the bladder is full, it might give an acoustic shadow which might limit further investigation. It is routinely used for the examination of especially the kidneys. Not the urinary bladder, but the kidneys are usually examined through the ultrasound. Next, we have the intravenous urogram. Now, intravenous urogram is the investigation or the imaging of choice in case of hematuria or renal masses, in which contrast material is introduced inside the urinary bladder, and then That contrast media is then further examined through a series of radiographs. Now, urine becomes opacified. Now, if there is any rupture in urinary bladder, that can be observed. If there is any rupture in the urethra, that can be observed. If there is any kind of filling defect or any contours or any kinks inside the ureter, even those can be observed with intravenous urogram. The next one is simple linear radiographic tomograph or plain CT. Now, this CT is unenhanced. Why? Because plain CT gives us an idea of how the parenchyma or the soft tissue of the urinary system is functioning. Next, we have the CT urography. Now, CT urography is the advanced form of the intravenous urogram. Now, instead of injecting the contrast media and then taking a lot of series radiographs, what we do is that we introduce the contrast media and then perform a CT scan. And through that CT scan, a much clearer image, more detailed image, and a 3D image is obtained. So CT urography is rapidly taking place of the IVU, the intravenous urogram. Next, we have the PET scanning. PET scanning has its value whenever there is a chance of carcinoma or metastasis. It is used both for the staging purposes and the evaluation of the treatment regimen. Next, we have the MRI. MRI has the least value in the urinary system, but it is still used in few instances. As you might recall that for renal artery stenosis, we do use MRA, that is the magnetic resonance angiogram. Next is the urinary bladder ultrasound. Now, one of the most common filling defect that we find on ultrasound is a renal polyp. Now, renal polyp usually arises from the mucosa of the urinary bladder, and it is represented on the ultrasound image as a filling defect. Now, here you can easily make out the urinary bladder and the filling defect that is presented. Now, this polyp has well-defined margin and its tissue is isoechoic with the other tissue. So there are no cysts, there are no further characteristics to it. So one can easily assume that it is a polyp. Next, we have the ultrasound. One of the most common renal masses is a renal cyst. Now, renal cysts are either simple or complex, and they are usually classified on a system called the Bosniak classification system. There are 4 levels to the Bosniak classification system. Level 1, which is a simple cyst, and it is usually benign. Level 2 is a cyst with thickened wall and usually has septa or septations or divisions in it. Level 3 is the one with thickened walls, thick septa, and sometimes nodularity in them. Level 4 or the class 4 cysts are the one which are hardly called cyst. They have huge or very thick walls. They have a huge amount of nodularity in their septa, and these are the ones which have the highest potential for malignancy. So if you find a class 4 cyst in your kidney or urinary system, the option of malignancy must always be explored. So this is a normal kidney with its renal cortex, with its fat, and this is a simple renal cyst. Now, this cyst is benign because it's a simple cyst, class 1. Next, we have the complex cysts. Now, there is a particular disease in adults called APKD, or the adult polycystic kidney disease. It is hereditary and it renders the kidney function totally insufficient, and it usually results in class 5 or grade 5 renal failure. Now, this is an example of an APKD with multiple cysts which are complex, different in sizes, joined together, has taken a place of the normal renal parenchyma, and because of this, the normal function of kidney has reduced and kidney has both enlarged in size. Now, this is a very serious disease, and whenever diagnosed or suspected, must be followed through and must be even be examined in the family members because, as like I said, it is hereditary. Now, whenever we find renal cyst, or especially the complex or multiple renal cyst, they are usually accompanied by hepatic cysts. They always have an direct proportional relationship to each other. Whenever you find hepatic cysts, they are usually renal cysts, and whenever they are renal cysts, we find hepatic cyst. Now, this is an example of hepatic cysts due to cyst in the kidneys. Now, this is a coronal T2 weighted MRI of a kidney, and this is a perfect example of an adult polycystic kidney disease. As you can easily see, there are innumerable cysts. There are a lot of them. Some of them are joined, some of them have thickened valves, some of them have septa, but all of them has taken place of the parenchyma, and the function, the physiology of the kidney is severely compromised. Next, we have a patient with both category 1 and category 3 cysts. So this is an axial contrast enhanced CT scan of the patient. This is a category 1 Bosniak benign cyst. As you can see, it's a simple cyst with well defined margin, but on its left kidney the cyst is a complex one, and it is of category 3 or class 3. As you can easily see, it has multiple septations, and septations are thickened, and it even has some nodularity to it. So in one person it is possible to have both the simple cysts and the complex cysts. Next, we have the renal masses. Now, as a rule, all solid renal masses are malignant, except for one example where if macroscopic fat is present, then it is considered benign. But other than that, all solid renal masses are always presumed to be malignant. Biopsy must always be done to prove their malignancy, but the presumption is always there. As you can see, this is a huge renal mass which has taken a lot of space in the abdomen. Next example that I was talking about. Now, this renal mass is the one I was talking about that has no malignant potential because it has macroscopic fat. It is essentially an accumulation or hyperplasia of fat tissue inside the kidneys. Now, this particular mass is called the angiomyolipoma, and it is never malignant, and it is considered benign. Next, we're gonna talk about hematuria due to renal calculi. Now, for the examination of calculi, what we do is that we perform CT scan and then we use the MIP, or the minimal intensity projection. Now here you can easily see that there is a filling defect here in the pelvis of the right kidney. Now because of this calculus, there is hydronephrosis inside the pelvis of the left kidney, and because of this hematuria is happening, because whenever the calculus inside the pelvis is of irregular shape or it's of spiky nature, it will scratch the normal parenchyma, and that will result damage to the normal tissue or the endothelium inside the ureter if it's present in the ureter, and that will result in hematuria. Next example is the one inside the ureter. Now this is not an impacted calculi. This is a calculi of an irregular shape with spikes, and it is damaging the ureter. Now because it is in the ureter, some dilation of the pelvis is happening, but some urine is passing through the ureter. And because of its nature, because of its spiky irregular nature, it is damaging the ureter, and the blood is flowing through the ureter into the urebladder, and that is resulting in hematuria. So in order to examine such kind of calculi, minimal intensity projection of the CT scan is always used. So this is a calcified calculi and inside the ureter. Our next topic is difficulty in voiding. Now, difficulty in voiding means that the person is experiencing difficulty in passing the urine, or is having problem in forming the stream of urine. Now, this problem can result either due to bladder outlet obstruction, can be due to some kind of stricture or stenosis in the urinary system, or it can be due to the prostate gland. Now, if it is due to the bladder outlet obstruction, mechanical causes must always be differentiated from the neurogenic ones, and these are differentiated through the physical exam. Now, if the reason is either a stricture or stenosis or some problem in the urinary system, that is done through the imaging. Now, for the strictures in the urethra, ureterocystogram is performed, and if the problem lies in the prostate gland, we perform imaging relating to the prostate gland. But it must always be noted that the carcinoma of the prostate does not usually result in difficulty in voiding, but BPH, that is the benign prostatic hyperplasia, that usually results in difficulty in voiding in the older men. Next is the modalities that we used whenever we encounter a patient with difficulty in voiding. So, one of the primary modality for imaging that we use is ultrasound. Now, that patient that is suffering from difficulty in voiding is given a series of ultrasounds, both pre-void and post-void, and both the volume of urine before the urination and after the urination is measured, and through which it can be easily estimated if the patient is suffering from bladder outlet obstruction, or if there is some kind of stricture in the urethra, or if it's of neurogenic kind. The other modality that is usually performed is a voiding cystourethropy. Now, in this technique, what we do is that we introduced contrast media inside the urinary bladder, and then we ask the patient to void the urinary bladder. And while the patient is voiding it, a series of radiograms are taken. And these radiograms along opacify the urethra, and if there is any stricture or any problem along the wall of the either the urethra or the urinary bladder, that can be diagnosed. So it is one of the most common modalities that is used whenever encountering difficulty in voiding. So, whenever a person is having difficulty in voiding, it usually results in pooling of urine, first in the urinary bladder, and that may give rise to complications such as infections. And then, if it's prolonged or chronic, then it gives rise to dilation of the ureter and pooling of urine inside the kidneys, and this is what is termed as hydronephrosis. Now, this is an ultrasound of a patient with hydronephrosis. Now, this is the kidney of the patient, and you can easily appreciate that the calyces in the and the pelvis of the patient is extremely dilated because of the pooling of the urine inside the kidney. And this is happening because the patient is unable to pass the urine. So these are the dilated pelvis and the calyces. Like I said, the pooling of the urine inside the kidney can result or can be because of strictures or the blockage of certain junctions inside the urinary system. Now, in this particular CT scan, the ureteropelvic junction is obscured. This is the ureteropelvic junction, which is obscured. As you can see that it is not continuous, and because of this, all the urine that is being produced inside this kidney is being pooled in the pelvic region of this person. And you can easily compare it with the right kidney, as this pelvis is normal with normal calyces. So this dilated pelvis is due to the obstruction of the ureteropelvic junction. Next, we're going to talk about urinary tract infection. Now, urinary tract infection is different in both males and females. Females usually present with cystitis, and men usually present with either urethritis or prostatitis, with sometimes complications arising in other areas, that is the kidney, that might result in pyelonephritis. So this is the urinary system of a normal human being. Now, urinary tract infections are always retrograde, that they are always due to they always come in the opposite direction to the flow of the urine, that through the urethra inside the urinary bladder, then they move upward towards the ureter, then inside the kidneys. Now, how they move through the ureter inside the kidney is because of the reflux. The urinary reflux is the cause of infection going all the way up to the kidneys. And if the infection reaches kidneys, that gives rise to the complication known as the pyelonephritis. So, if a person has UTI, the modalities that we use is again avoiding cystourethropography, which gives us both if a person has a stricture in his urethra or if the urinary bladder has thickened walled due to the infection, if there's pooling inside the urinary bladder, whatever the cause, if that cause lies in the urethra or the urinary bladder, that can be diagnosed through the voiding cystourethropography. But for other modalities can also be used. Simple ultrasound can be used to determine if the walls of the urethra and the urinary bladder are they thickened or not. We can even use radionucleotide cystogram, but it is rarely used and only used if there's suspicion of carcinoma. The most typical carcinoma of the urinary bladder is transitional cell carcinoma. We can even have CT scan and renal scintigraphy. But these are rarely used and are only used in very, very specific conditions. MRI, even though it has its purpose, it is rarely used whenever encountering a patient with urinary tract infection. Now, first for the VCUG. Now, this is a patient in which the contrast media was introduced in the urinary bladder, which has resulted in the opacification of the urine. As you can easily see that the walls of the bladder are easily marcated. Now, its ureters are showing different types of reflux. Now, there are usually 4 grades to the reflux, either grade 1, grade 2, grade 3, or grade 4. Now, this person has grade 1 in the left ureter and grade 3 in the right ureter. Now, grade 2 reflux of the ureter can easily be diagnosed by seeing that it is not dilated much, the walls are not thickened, and there is no tortuous element to it. But in grade 3, there is some tortuous element and it is highly dilated. And because of this reflux, the urine is moving upward towards the kidneys, and then the kidneys get infected. Now, this is the lateral projection of the same person, but in this we can easily see that this is a class 4 reflux. How? Because the dilation is more than the class 3, the tortuous element is much more than the class 3, and the dilation is so much so that it almost equals to the opacification of the bladder and the renal pelvis. Next is the severe pyelonephritis. Like I mentioned, the most common and severe and the complication with the most morbidity is pyelonephritis, that is the infection of the parenchyma of the kidneys. Now, in this CT scan, one can easily appreciate that there is renal abscess inside the kidney. Now, there are multiple abscesses, and these abscesses have thickened valved, and because of this, and now these abscesses are not sterile because of the reflux. They are infective, and if they get burst, ruptured, they give rise to further complication, that is septicemia, that might prove fatal to the patient. Now, one of the causes of pyelonephritis in a patient is when patient has spongy kidneys. Now, spongy kidneys are the one where the patient has renal tubular atresia, that its renal tubules or nephrons are not of good shape. That results in a spongy appearance of the parenchyma of the kidneys. And whenever pyelonephritis happens in those kidneys, it gives rise to not only renal interrenal calculi, but it also results in small abscesses throughout the kidneys. And it is one of the most deadliest complications of pyelonephritis. Our next topic is renal failure or insufficiency, or it is also called as chronic renal failure or CKD, chronic kidney disease. Now, in CKD, imaging has a very reduced role, but it still has some importance. Now, imaging in CKD is either used to rule out any kind of obstructive uropathy, either it is in the upper urinary tract or in the lower urinary tract, or it is used to rule out any renal artery stenosis, for which we either used MRA or the CTA, that is the magnetic resonance angiogram, or the CT angiogram, or we use it to stage the CKD. Now, in order to stage the CKD, what we do is that we have 5 classes, and all of those are based upon the GFR or the glomerular filtration rate. The first one is the one where the glomerular filtration rate is minimally reduced, and grade 5 is the end stage renal disease where the renal failure is maximum. Now, in order to measure which renal failure or the stage in which the kidney lies, we use contrast media, and that contrast media then gets filtered out through the glomerulus, then into the nephrons, forms into the urine, and out through the body. Now, the amount of the contrast media that is filtered through the glomerulus gives us which grade of the kidney failure the person's or the patient's kidneys is in. Now, even for the contrast media, we have 2 options. Either the contrast media is of gadolinium type or of the iodine type. Now, if the person is in the first 3 stages, we usually prefer the gadolinium based contrast medium because iodine based are nephrotoxic. But if the person is in the 4 or the last stage, we prefer the iodine one, because then the gadolinium based contrast medium can have certain effects such as the fibrosis of already very much damaged kidney. So even minor changes in the parenchyma of the end stage kidney disease is preserved, and that can only be achieved if a person or the doctor or radiologist is well versed in the choice of the modality or the choice of the contrast medium. Now, another thing that we use in chronic renal failure is that we try to find out the physiology or the parenchymal sufficiency of the kidneys. For that, ultrasound is used, and sometimes even technetium 99 MAG3 radionuclide scans are also used. Though they are used very rarely, their importance is still there, because in some cases grading is not sufficient because of that particular problem. That particular glomerulonephritis has defining characteristics that does not put it either in the third class or the fourth class or the last grade. So we perform the technetium radionuclide scanning. Now here I have the ultrasound image of a person with a kidney in its end stage. Now here you can easily see that there is no dilation of the pelvis. The cortex is minimally present. There's thinning, and the medulla or the pelvis is replaced with the sinus fat. So this person has end stage renal disease, and the imaging will provide us with answers that how much GFR he has, or he or she has, or how much further down the treatment or evaluation we can perform. Our last topic is the prostate gland. Now, the prostate gland is specific to the male anatomy, and it lies inferiorly and posteriorly to the male urethra. And any problem to the prostate gland results in the urinary problems in the males. So the most one of the most common problem that one experiences with the prostate gland is the BPH, or the benign prostatic hyperplasia, because about 80% of all men above the age of 50 have BPH, and BPH usually results in difficulty in voiding and may even result in urinary retention, and then urinary retention results in infection, and then infection may complicate into pyelonephritis. So you can see that the examination of prostate gland is of utmost importance whenever encountered or whenever it is found out on the physical exam. Now, in order to examine or image the prostate gland, the modalities that we use are: the first one is the transrectal prostate ultrasound. Now, if there's a suspicion of either BPH or prostatic carcinoma on the physical exam, it can be confirmed through transrectal prostate ultrasound. Now, not only can it be confirmed, but this modality can also be used to take biopsy of the prostate gland to confirm the diagnosis of either the BPH or the carcinoma, or if the carcinoma is suspected, what stage it has, what kind of cellularity it has, all of those can be determined. So this particular modality is of particular use in the interventional radiology. Then we have the CT scan or the MRI. Now, if we want to know more about the prostate gland, that which lobes are involved, how are they putting the pressure on the male urethra, or which lobe is not involved, or we want a more detailed picture of the prostate gland, then the unenhanced CT scan or the MRI is used. Another one is the radionuclide bone scan. Now, we use radionuclide bone scan because the most common complication of prostatic carcinoma is bone metastasis. Now, bone metastasis is usually of two types. Either it is of diffuse type or focal. Our next radionuclide image is of diffuse one. Now, to the untrained eye, it might look that it is normal because there are no particular focal points and all of the bones are visible. But for the trained eye, one can easily see that all of the bones, especially the dense parts, are highly active. So this person has bone metastasis but of diffuse kind. And this kind of diffuse bone metastasis can take up to 5 years to have some kind of focal appearance on the PET scan or the radionuclide scan. Next, we have the sagittal view of a person with bone metastasis, but it is of the focal point origin, and it can be easily seen that the bone density of all the area of the vertebra and its spinal process and the sternum is increased at irregular areas and irregular pace. So these are all bone mets due to prostatic cancer. So, in the part 2 of uroradiology, we studied about hematuria. That hematuria is either of microscopic or macroscopic kind. We learned about the site of hematuria, that it can be either in the upper urinary tract or the lower urinary tract. And whenever hematuria presents, it is of utmost importance that it must be evaluated further. Then we learned about the renal masses. We learned that renal masses are either of cystic origin or they're solid masses. Now, cysts have particular system to them called the Bosniak system. They can be simple benign cyst, that is the class 1, or it can be a class 4 complex cyst that has the maximum malignant potential. We also learned about the solid renal masses and the presumption that solid renal masses are always malignant, except for the one case where the angiomyolipoma mass is not malignant. Then we learned about the UTI or the urinary tract infection. And we learned that urinary tract infection follows a retrograde route, that it follows from the urethra to the urinary bladder to the ureter to the kidneys against the flow of the urine. It accomplishes that because of the reflux. And again, the reflux of the urine towards the kidney from the urinary bladder again has its categories. It can be category 1, category 2, 3, up to 4. Now, because of this reflux, the lower urinary tract infection can result in upper urinary tract infection or the pyelonephritis. That is the presence of the purulent material inside the kidneys or the presence of the abscess inside the kidneys. Then we learned about difficulty in voiding and how difficulty in voiding is either related to mechanical bladder outlet obstruction or enlargement of the prostate gland or some kind of stricture or stenosis inside the urinary system. Now, if the stricture is inside the urethra, it is usually due to the trauma or an infection, or if it's in the upper urinary tract, it is usually congenital. Then we learned about the renal insufficiency or the renal failure or the chronic kidney disease. We learned that imaging has some part in the CKD process when we have to rule out the obstructive uropathy, or we have to rule out renal artery stenosis, or we want to place the renal insufficiency or failure into its categories by using various either gadolinium or iodine based contrast medium. Then we learned about the prostate gland. That prostate gland can result in both in difficulty in voiding, but it is can also result in carcinoma. Now, the prostate carcinoma has a very particular characteristic that it results in bone metastasis. And bone metastasis are either of the diffuse kind or of the focal kind. We learned how the diffuse kind manifests on the radionuclide scan and how the focal kind manifests on the radionuclide scan. We also learned about the BPH, the benign prostatic hyperplasia, and how it is present in more than 80% of the men in the age group of above 50. So that was the Uroradiology part 2. Thank you for watching sqadia.com.